The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome. We are gathered here for the next episode of TMD Demystified. My name is Tony Urbanek. Today's title is TMD and emergency rooms, TMD and emergency departments. I have a lot to say about that. Hopefully it'll be helpful to you, whether you be a provider or whether you be patient. A little knowledge about what goes on within the emergency departments, emergency rooms, and TMD will give you some assistance to understanding where you might guide or not guide patients as far as finding solutions to their problems. I think that's my point here. So I have, as a board-certified, doubly qualified dentist and physician, academician, well experienced with what my colleagues do, my emergency room colleagues do in emergency rooms. I've spent the better part of 50 years treating facial trauma in the emergency departments, emergency rooms throughout Middle Tennessee. At one time, I was on staff at seven separate hospital emergency departments in my younger years. I don't do that anymore. In fact, I don't do any surgery anymore. My practice, as you well know, is limited to the non-surgical treatment of TMD and the use of a special, easily understood device that does nothing more than unload the temporomandibular joint to allow the inflammation to go away, which causes the symptoms to go away. But today's topic is what goes on in emergency rooms when you as a patient or you as the provider, the doctor who is trying to treat patients with these symptoms, the patient ends up in the emergency department. It surprises me. I haven't thought about it much. I assumed that, well, I knew what would go on in the emergency room, I assumed that most dentists would understand that an emergency room, emergency department, is not the place to send a patient who has any of the symptoms of TMD. I don't claim to express the same feeling about how patients feel about going to emergency departments, because they are in desperate need of help. And whether it be during usual business hours or after hours or on weekend hours, patients are desperate when they have some of these symptoms that have been going on for some time, sometimes for years, and sometimes very acute periods of time. They think that the emergency department is the place to go for the solution. So let's just start at the beginning a little bit about pain itself, because that's what drives patients into the emergency department, is pain. They won't go to the emergency room with ringing in the ears, tinnitus, subjective hearing loss, vertigo. That will not send them to the emergency department. What sends them to the emergency department is extreme levels of headache, jaw pain, ear pain, and neck pain. Those four symptoms are the most common symptoms associated with TMD, temporomandibular joint disorder. And when they are severe enough, patients are desperate enough, they will go to the emergency department. So first of all, let's just define pain specifically. Define what is pain. So according to the International Association for the Study of Pain, ISAP, I'm reading verbatim off of my last blog, which I wrote this weekend, which is confluent or parallel to the podcast that I do every Tuesday, this podcast. According to the International Association for the Study of Pain, IASP, pain is defined as an unpleasant sensory and emotional experience, I want to emphasize that, associated with actual or potential tissue damage or described in terms of such damage. That is the official definition of pain. It can be physical, it can be emotional, or a combination of both. And usually pain, physical pain, usually has a significant emotional component too, because it brings up fear. A lot of pain then will create fear in the patient, which drives the emotions, and frequently fear itself drives the patient in the emergency department. So what happened was I chose this topic because just a couple days ago, I had 2 patients within a span of 3 hours in my clinic that came in with histories of going to the emergency department with the intent of having the emergency room solve their acute pain associated with TMD. Now, neither of these patients knew at the time of their arrival in the emergency department that's what their problem was, but they went to the emergency room. They did not know that what was causing the pain, but they knew they had significant pain. So 2 separate patients within one clinic 3-hour period got me to thinking about, I need to talk a little bit about what really goes on in emergency rooms with patients who present with symptoms associated with TMD, whether or not the patient knows that the symptoms are created by TMD, they've had previous diagnosis or experience, or they've had no previous diagnosis or experience. Sometimes emergency department doctors are clever enough where they can actually rule out all other evidence of the pain or all other causes of the pain, and sometimes they can. But the point is that the emergency room doctors basically have no idea the mechanisms of what cause TMD, and that the best that they can do, the very best that they can do, and I emphasize the very best that they can do, is prescribe pain-relieving drugs. And that certainly is only a very temporary thing and doesn't get the patient down the road very far at all. That's the best that they can do, but in my experience, both of these patients basically had no understanding of what caused their pain and were just led down the rosy road of, well, you need to go see your physician, and given some pain medicine. And that's what caused this. Now, I looked into this. I contacted one of our local emergency departments and found out that if the emergency room doctor actually suspects that the patient has TMD symptoms, that the painful symptoms, the severe, unrelenting headaches, bad headaches, bad earaches, bad neck pain is coming from the temporomandibular joint, what do they do? Well, I'm going to tell you about it. I'm not going to identify the hospital because it's not very flattering at all. So I'm not going to identify which hospital in Middle Tennessee this is directed by, but they have a handout, a literal handout that goes on for 4 pages, which by my observation and opinion, now next is opinion. I always separate fact from opinion. This handout is given to satisfy the attorneys so that they can honestly say they did something. They did something for this patient when they came in. But I just want to read part of this. I'm not going to take you through the whole thing, but it's all boilerplate. It's just, it's not smoke and mirrors, because some of what is on here is factual information, but it's word salad to satisfy the patient that something is understood about it and something is being done when actually nothing is being done. But I just want to read a couple parts of this for you from actual document generated by one of the better known emergency departments here in Nashville, Tennessee. And it talks about what the TMJ syndrome is. They call it the TMJ syndrome, temporomandibular joint syndrome, which is really not accurate. I talked many times before. TMD, temporomandibular joint disorder, is one disorder. It is a syndrome, actually, because it has multiple problems. It has multiple things that going on, symptoms, multiple symptoms caused by one fact is called a syndrome. So correctly so, they do call it a syndrome. And I'll just read you the first paragraph and a couple other parts. TMJ syndrome, the temporomandibular joint is the joint that connects the lower jaw to the skull. You can feel it in front of your ears when you open and close your mouth. TMJ disorders cause chronic or recurrent pain and problems of the jaw and the muscles that control the jaw movement. Symptoms of TMJ disorder are usually relieved with minor treatments. Not true, but symptoms may come back, especially in times of stress. Well, that is true. Symptoms do come back. They always rotate over time. Every time they come back, they hurt more, stay longer. But this is the sentence I wanted to read to you, because it tells the difference between what I have discovered and our point of view and what I've discovered and what we have found to be true on independent university study and over 5,000 people. But here's what the emergency room states. Causes for TMJ syndrome. There are no widely agreed upon causes of TMJ disorders. And it's only one disorder, not multiple disorders. It's a syndrome because it has multiple symptoms. It does have multiple symptoms, but it is one disorder. It is not multiple disorders. They have been linked to stress. True. Injury, arthritis, genes. Well, that is not true. We do not know of any genetic. It is familial. We know that it is familial in that it runs mother to daughter very frequently. And it's primarily a female problem because estrogen exacerbates inflammation. That is a fact. Academic, in the literature, proven fact. But it is not genetic because we never identified a genetic cause, actually gene cause, and how someone feels pain. And then it goes through the symptoms, which I went through specifically. They're more generic symptoms that they give here. And then it basically talks about home care. If you go to the emergency department and you present with whether you know the symptoms are TMD or the emergency room doctor figures out the symptoms are associated with TMD, they are going to give you a 4-pager of boilerplate, and it basically will tell you the solution is to relieve stress. And so it goes in home care, what you can do on and off heat, things that are helpful, but mainly a 1.5 pages of how you can relieve stress. And the only thing we know for sure about stress, it is related to bruxism, and bruxism is related to damage within the joint. This is true, but if you go to an emergency department, and somebody figures out it has to do with TMD, this particular hospital is going to tell you, you need to go home and relieve your stress. And they will give you some kind of pain medicine, but basically this word salad is also going to tell you use ibuprofen. which is a good drug. It's a non-steroidal anti-inflammatory, but by the time somebody has a good case of protracted up and down TMD symptoms over a period of months or years, they've already been well through using ibuprofen, which is a extremely effective non-steroidal, but only for a short period of time, and then you run out of steam. And it clearly gives in this article, series of pages, the important knowledge that you can't use it very long because it can damage your liver and your kidneys, ibuprofen. So you get a couple weeks out of effectiveness of ibuprofen, or maybe sometimes just a couple days. Then it tears up your stomach like aspirin does, which is also a good anti-inflammatory, but more prone to cause gastric pain, gastritis, than ibuprofen. And then if you use either one too long, you can damage your liver and your kidneys. But this is the information that comes from the emergency department. That's as far as they get. And they admit as everyone else admits, they don't know what causes TMD, which is not true. What causes TMD is damage to the temporomandibular joint due to bruxism, acute trauma, or functional malocclusion, where your jaws don't fit to the point where you overload the joint. All three of those things, episodes, concepts, what they do is overload the joint. Just like you overload a knee, it damages the knee. Well, you overload the temporomandibular joint, damages the temporomandibular joint, creating chronic inflammation, and it's the chronic inflammation that creates the symptoms. Again, refer to prior episodes about this. I've discussed it multiple times. We're not going to go through that. We're talking about what you need to expect as a patient or a TMD doctor or just a dentist who tries to understand TMD, or even a physician who's trying to understand what's going on with TMD, that the emergency department is not the place to get good information and certainly to get good treatment, because they admit that they don't know, at least they admit they don't know what's going on. They don't know the cause. And the best they can do is prescribe some anti-inflammatories. At the worst, they'll give you some narcotics for a short period of time. But because of the circumstances of our culture, emergency departments, as are most providers, most doctors, are very hesitant to provide narcotic support, opioid support, only for the most extreme cases, or surgical interventions is when it's usually used. So I wanted to make it clear that emergency departments are not the place to get treatment. Reducing stress. I mean, that's the theory, the concept behind it. Reduce your stress, and that's going to fix the problem. It's going to reduce your bruxism, and because bruxism causes the damage, then well, the damage is already done. And you can't stop using your jaw. You're going to talk. You're going to speak. You are going to eat, move the jaw, continue function on the jaw joint. And if you are a bruxer, you're going to continue to brux. There is no on and off switch on the bruxism. It is true, the more stress you have, the more you'll brux. But if you're a bruxer, you're going to brux. Under minimal stress, great stress, if you're a bruxer, you're going to continue to brux. There is no on and off switch. So to tell somebody, well, just reduce your stress, that's going to reduce your bruxism, and that's going to solve your problem, not going to happen. And then the last remark here is, if that doesn't do it, then go see your doctor, go see your PCP, and ask him what to do. And that's where we get into this vicious cycle of doctors referring doctors to doctors, who then refer patients to other doctors. You go from your emergency department to your PCP, to your ENT, back to your PCP, maybe a referral out to a physical therapist, and who knows where. And basically, they're just treating symptoms of pain, and this the big driver of TMD is the symptom of pain, but never gets to the point where anybody understands what's really going on, what the pathophysiology is, which is simply chronic inflammation. If you unload the joint with a device according to a protocol, which is quite simple. Protocol is 24/7 for 2 months, nighttime only for the rest of your life. And you use it properly as a proper tool to use, and you understand why you're using it, how it works, what you're doing, you will get the result. So that's what we do here. That's what I know, and the other doctors in our network throughout the United States also know that if you use it properly, the patient uses it properly, you get the results. It's proper. If you know how to use the tool, you'll get the result. So I've made my point. Emergency departments are not the place to look for help, unfortunately, for patients. And I'm not criticizing my emergency room colleagues. I have great respect for my emergency room colleague doctors. I worked elbow to elbow with them for the better part of 50 years. I know what they do well, and I know what they don't do well. And one of the things they don't do well is temporomandibular joint issues. But I do respect them, and I definitely respect patients who are so desperate that they don't know what else to do. And many of these patients have already seen many doctors. This is the problem we are trying to solve in getting the circular motion, this constant rotation between doctors and patients who go on sometimes for months or commonly decades, going from doctor to doctor, seeking care, being misdiagnosed, mistreated unintentionally because of misdiagnosis, and not getting anywhere with the symptoms. So the ultimate comment about this episode is this. If you have any other option, don't go to the emergency room. If all else fails, come to see us, because we know we have the answer. The emergency room, by the way, is the most expensive way to treat a problem. The average visit, I looked it up, the average visit to the emergency department is between, the average throughout the United States is between $750 and $2,600, and that how it's paid is dependent upon, and how much it's cost and charged is dependent on whether or not you have insurance and what kind of insurance you have. So insult to injury, not only do you get the help, but you end up with a big bill. I think I've made my point. If anyone would like to discuss this with me, I'm available. I encourage contact. If anyone would like to criticize what I talk about or my topic, I can be reached at tony@tmjservices.net. For the doctors out there who are already not on and in our network of providers who know how to use this device and protocol with their patients, that information is available at www.urbanektmj.com, urbanektmj.com, urbanektmj.com, where potential network providers can learn how to take the course and be licensed to use the device and protocol so that they can help our patients and keep them out of the emergency departments. Until next time, I am Tony Urbanek, and this is TMD Demystified.